Welcome back. For those of you who are new, I see a couple of new folks. I'm Anna Hoover. I am the co-director of the Systems for Action National Program Office. Welcome. We're glad you could join us. Today we are hearing from a couple of our Mentored Research Development Awardees through the Public Health Services and Systems Research Program. We are very excited to have them here. This work aligns very well with some of the cross-sectoral directions that we're going to be going with the new Systems for Action Center. So it is my pleasure right now to introduce to you Dr. Brian Dixon, who is an assistant professor of epidemiology at the Richard M. Fairbanks School of Public Health at Indiana University and Purdue University in Indianapolis, or Ooey as we call it, and is also a research scientist with the Regenstrief Institute Center for Biomedical Informatics. We're very excited to have you here today, Dr. Dixon, and we look forward to your presentation.
Thank you very much.
Thank you.
All right, so I'm going to start briefly with a little bit of background for me because I wasn't sure who would show up for the talk, and then I'll get to the meat of the discussion. First of all, I wear multiple hats, so people, I always tell my students, I'm somewhere on campus, just never in the same place on any given day, so they have to track me down. So I spend about a third of my time teaching and doing mentoring with our master's students, our MPH students, as well as our doctoral students, both in EPI and in our School of Informatics, where I used to be before our School of Public Health was created. We are 2 years old now and just got CEF accreditation this past June, so we're the new kid on the block when it comes to schools of public health, but that's okay. We're excited about that. And then I spend about 70% of my time doing research, and I split my research actually between a lot of the work that I do at Regenstrief and our Center for Biomedical Informatics and Center for Health Services Research with a small appointment, which recently this month got a little bit smaller, which is okay, at our Center for Health Services Research and Development at the VA Medical Center in Indianapolis. So I also am a part-time VA researcher, and so it gives me a chance to practice and teach and do research at multiple environments, and my research focuses on the intersection between public health and health services research, hence the PHSSR focus, as well as the intersection between the world of biomedical informatics with both health services research and public health. So generally I hang out in the overlapping areas where I do things like focus on health information exchange and decision support, which I'll talk about today. In other projects I focus on things like surveillance and veterans' health issues, and talking about the usability or design of IT systems that are used both in healthcare and public health practices. Okay, so my agenda for this talk is to talk about the concept of population health decision support, which is sort of the framework for our project, for our intervention study that I'll talk about. I'll talk about case reporting, public health case reporting as it used to be, and as we're trying to modify it in our project. Then I'll talk about our intervention and some preliminary findings from our work with some recommendations. So first, generally in informatics, one of the core areas of informatics research and practice is in decision support. In fact, we had a nice question during your talk about decision support. And so CDS is typically defined as the use of a computer to bring relevant knowledge to bear on a clinical decision that's being made. And so it's generally informing a clinician about the patient that's sitting in front of him or her at the time of a clinical encounter, and with the outcome hopefully being better health outcomes for the patient. And so the general philosophy and theorem in biomedical informatics is that if human brains and computers work together, it's better than if the human brain works alone, because it's hard for practitioners to retain all of the knowledge of what they learned when they were in medical school or public health school, and then when they transition into practice and keeping up to date on everything as knowledge changes. So how does this notion fit into the sphere of public health? This figure actually comes from the Office of the National Coordinator, and so although I don't endorse it 100% because they say that public health it should just fit here between the span of practice and population. I would sort of extend the arrow another link to think about the entire public and citizens and everything, not just confine it to this space. It sort of gives you a sense for where public health fits in with respect to decision support. So they have decision support down here as sort of practice, at a practice level, informing the patient care making. Public health fits in at the population level by sending information and knowledge down to both clinical practices for translation to both individual patient care as well as now management of populations. So a definition of population health decision support might be defined as using the computer to bring relevant knowledge to bear on the health and well-being of a population instead of an individual patient. So some examples for stuff that's happening today in routine practice is vaccine forecasting. So every state has an immunization registry. That immunization registry has the capacity to forecast vaccines that are due for an individual child. And so those reports are delivered to clinicians who have the capacity through their EHR to request those reports. Also, some examples, there was a study in New York City a few years ago where they linked knowledge from the public health department to EHR systems so that in the time of a salmonella outbreak, they could inform and recommend ordering a stool culture when a patient presented with certain symptoms like a GI, so they looked at a chief complaint of a GI disorder or having, having some sort of issues, and then the EHR could then prompt the physician to order the stool culture because they wanted to sort of manage that outbreak better. So that's an example of PH decision support. Many of these are more theoretical than in practice, but this is the possibility that we have as electronic health record systems are introduced and used in the clinical world, and we in public health world can tap into them and leverage them to support population health. So, a traditional workflow in population health and public health is case reporting. So there are certain diseases that are required under state law to be reported by clinicians to public health departments so we can do surveillance and monitoring and outbreak management, detection and management. And so the way this is traditionally done is that the lab will run a test and then report the results to the physician, who will promptly run over to a drawer and pull out a paper form, fill it out, and send it into public health. And so this is the way it has worked for decades, the design of the process. And of course, about 15 years or so ago, we also started requiring labs to concurrently report directly to the State Department of Health in addition to the physician so that we could capture more information about cases. But of course, this has some challenges. Providers often forget to report the information to public health. This is the official state reporting form in the state of Indiana, where I'm from, and it has essentially three main sections. One is information about the patient. One is information about the lab test that was done and the results, and the specimen source, and so on and so forth. And then finally, information about the provider. The physician's name, their phone number, their address, so on and so forth. And then there's a section at the bottom which is for the health department's internal use. But if you notice, a lot of these sections are pretty commonly captured by electronic health records, right? So is it possible, in our project, we said, is it possible to pre-populate this form with electronic data to improve the process of public health case reporting? So we created an intervention that essentially sits between the lab and the provider. So the lab does its routine laboratory work, finds a positive case of salmonella or chlamydia or gonorrhea, and then it forwards that information through electronic laboratory reporting to the physician like they always do. We intercept that within our health information exchange, which is a network of different clinical information systems that we have integrated in the state of Indiana. We detect that result. We then pre-populate the state-based reporting form, deliver that form electronically out to the clinicians in their practice, where they can then complete a couple of the sections that the laboratory has no idea anything about, right? Like treatment, because one of those sections is treatment. But the lab doesn't know about treatment. They just know that we did this test on this day with this specimen source, and this was the result. And then our hope is that the intervention would then be completed, the form would be completed and submitted to public health. And that we could use this intervention to improve reporting rates among providers, which is chronically low, and we can improve the completeness of the documentation and the timeliness with which it gets to the health department. So our intervention builds upon core infrastructure that's available in our health information exchange. So for years we've had an automated case detection algorithm and software that runs to identify notifiable diseases from routine laboratory results and move those data electronically to the health department. So as I mentioned before, labs have a responsibility to report data to public health just as providers do. And so for several years, we've done work with our health department partners to automate that process of moving the data from the lab side to public health in order to improve their awareness and knowledge of disease that's happening rather than relying on the labs to manually report that. And we did that with some success. And so in this project, we decided to extend that to the clinical providers as well. Also, our intervention builds upon our work previously in clinical messaging. So this is getting information to the right person at the right time using clinical information systems and in a way that's integrated in the clinical workflow. And so we used our system relies on a messaging system that's been available in Indiana for over a decade that physicians routinely use today to go and get their radiology reports, their dictated notes from specialists, their laboratory results. So they're going to this system anyway instead of creating yet a new website that they have to log into or a new widget or app or something that they have to download. And finally, our intervention builds upon existing public health communication pathways. So as I mentioned before, we've had ELR for many years in our state. This builds upon that. And then we also, the last mile of this today is largely fax communications because that's what most public health departments have the capacity for today. And I start a couple of these things because they align quite well with the Meaningful Use program, which is pushing adoption of electronic health records into clinical practices. So clinical messaging is a specific measure within, and ELR are specific measures within the Meaningful Use program, both in stages 1, 2, and now 3. All right, so our notifiable condition detector, or NCD, is our automated case detection software that we've been using for a number of years. Essentially, it takes all inbound messages to our health information exchange that have a source of the laboratory, identifies those things that are reportable using a subset of codes from what we call the Dwyer tables, or now the CDC's reportable conditions mapping table, and that table says these things should be reported to public health. We then check the results of those messages to see is it positive or negative, and if it's positive, then we go ahead and forward it on to public health. We can do that both. We do that both on an individual basis, sending the individual ELR messages to public health, and we also do some aggregation of the data to monitor counts. We give those as daily summary emails to public health departments at the local and state level, as well as to infection control practitioners in our major health systems. So the triggers for case detection are based on codes that come into the messages we receive. So we look for ICD-9 codes. We look now for ICD-10 codes. We look for SNOMED CT codes. That's a very clear signal that this is a potential diagnosis that we need to report to public health. So if we get data that's encoded using the data standards available in healthcare IT, we can easily detect that but we don't get that so often. So we have to do some mapping and translation of things into those code sets. We also do the same thing on the laboratory side. There's a data standard called LOINC, which is a clear signal of the test that examines for a particular public health condition. And so we look for those things. If we don't find them there, then we translate the message into those standards so that we can then make a determination using the reportable conditions mapping table. We also, for things that are the results that are text-based, so things like microbiology results, we have to use natural language processing to analyze the results. This is challenging, but it's necessary, even though, because these text blocks are sort of dumped into the standard messages that we receive, so we have to parse through them and sort of sort through from, say, a generic stool culture, all the different things the lab tested for, and they'll say, we tested for this, and it was negative, this, and it was positive, this, and it was negative. And so we have to sort through there and find the things that are positive and compare it to that list. All right, so once we have detected that we have something that needs to be reported to public health, we can then go and generate our form and deliver it out to the clinician. And we do that using our Docs for Docs system or service, which is part of the Indiana Health Information Exchange, our HIE partner. And so their system provides a portal that the physicians log into, or the nurse case managers or someone at the practice logs into, and when they log into that, they receive a listing of all of the patient reports that are coming back in real time for all the different doctors in the practice. And so they're monitoring this, as you can see, for things like laboratory, routine hematocrits, CBC with differential, let's see what else is on the list. There's urine cultures, so on and so forth. So lab results, there's radiology reports, etc. Each report that comes in is standardized on the header to sort of clearly identify this comes from XYZ Medical Center, and it is for patient John Doe, and this patient has a birth date and a medical record number, and so on and so forth. This information at the top is standardized. Then the body of the message is whatever the data source is sending. So the lab result, radiology note, whatever it is. And so it's a very routinized process, and so people can find information quickly. And so what we did then is built on top of this to start dumping things into this box that are not associated with a particular patient, or that are associated with a particular patient, and are identified as a new document type of disease reporting for the Indiana Department of Health, with document details being public health notifiable condition. And it just queues up in the same pattern. And this time when the physicians click on it, they see the standard-based reporting form from the health department. So again, the header identifies who's sending me this report and what is it pertaining, and then the body of the message, we pre-populate with the information about the patient's name, address, so on and so forth. We check boxes for things that are box checked. So again, pre-populating the form to get it right in front of them in their clinical workflow. So then what happens? Well, today the clinics have to fax things back to public health because even in our urban areas, our urban health departments are receiving information via fax. That's their workflow, so we need to accommodate their workflow, and today it's fax-based. We are talking to the state health department about potentially expanding this into electronic delivery from EHR systems directly into their INED system or NEDS-based state system in the future, as they have the capacity to make modifications to that system, which is a challenge for public health departments to upgrade their systems, just like it was for clinical practice before they got $30 billion from CMS to do that. So in our particular project, we are addressing certain conditions. These are the conditions we're focused on. They break down into two general categories, which is vaccine preventable and others. So we're looking at things like hepatitis B, chickenpox, rubella, mumps, and measles on the vaccine preventable side. And then on the other side, we're also looking at routine things like STDs, hepatitis C as well, histoplasmosis, and salmonella. So it's a range of things that are common and routinely done, mixed with some things that are more rare. It's also a mix of things that are heavily, numeric based for some of the interpretations of the test, with things that require the more harder microbiology results. It's also a mix of things that also require a lot of additional details for case follow-up, like hepatitis C, where you want liver enzymes, with things where, like chlamydia, you just need to know that it was diagnosed, it was treated, case closed, move on to the next thing. So a combination of things to give us a variety of conditions to look for when we're testing our intervention. So where are we in the project? We have, at this point, collected and are analyzing, finalizing the analysis of all of our baseline data. So what did it look like before we went live with the intervention? We did go live with the intervention in June of last year, and we ran it for 12 months. And so we're finishing the data entry on the post-intervention phase because we're waiting a couple of months after the end of a month to go and collect case files from the health department, because sometimes they get additional reports from infection control practitioners and others about a case before they close their case files. And then we have some student workers who are helping us enter all of the data. We're basically collecting case files from the health department, doing manual abstraction of the data from those files in order to build out our study database, in addition to having the ELR data, which we can easily extract from our own systems. And then we're starting now preliminary analysis of the post-intervention data, which is slowly evolving. So what do we have on the baseline? So this is for the vaccine preventable diseases only. We had about 4,000 cases for about 3,700 unique patients. So there are some duplicate cases for people. And then about 98% of these were for hepatitis B. So the other cases are very rare, thankfully. We don't have any, we did not observe during our year-long intervention or even in the baseline period any measles outbreaks, any rubella outbreaks in our data set. So most of these things are standard hepatitis B. And then reporting rates were pretty bad for HBV. But they were pretty good for the others. So it seems like providers pick up on things that are more rare, and I'll talk about that in a few moments. But things that are more routine, they have a harder time remembering to report to public health. And automated case detection from ELR identified 100% of the cases. In fact, it identified duplicate test results for some of the patients, and we put into those cases because there might have been preliminary results followed by final results from the lab, so on and so forth. So here's the reporting overlap in a pictorial graph. So you can see ELR picked up a lot of unique cases that the other reporting systems did not pick up. So the passive provider reports did not report everything that the ELR picked up. The lab did not manually report everything that ELR picked up, but that is okay because the labs, we've had 10 years now of ELR, so the labs are not used to manually reporting anything anymore to our state health department because they have become addicted, or not addicted, but accustomed to the ELR being there, and they sort of just rely and trust that it's going to get to the health department. But on the provider side, there were a few things that providers reported that our ELR system did not detect, but it's a very small percentage. All right, so baseline completeness. So we looked at both completeness and timeliness of the reports. And so interestingly, On the provider side, for vaccine preventable diseases, especially for the more rare cases of disease like measles, it's very good completeness of the reports. It ranged from about 45% complete to 100% complete, each field did. And facts-based reports from the lab had a similar high rating, and ELR was a little less, which kind of surprised us because when we looked at very similar results for things like STDs, we find the opposite is true. So for STDs, the ELR report is very high on completeness, and the provider reports are pretty sparse on completeness. So it's interesting that for vaccine preventable diseases, it's the opposite. So in just 3 out of the 15 kind of core fields did ELR outperform provider reports, which, and it's interesting, test name is one of those things that it outperformed. Providers often don't write down what tests they did or what tests they ordered. They just write down chlamydia, or not chlamydia, I'm sorry, not chlamydia. They write down rubella positive, right? And then, but you know, which test did they do? They don't remember, but at least we have lab results for those cases that we can provide. And that's the importance of having ELR. And then it's interesting that providers seem to report things more completely for the rarer diseases. Now we think, our hypothesis is, and I'll get to this in a moment of the work that we have yet to do, which is to integrate some qualitative work that we did in addition to these quantitative results. We think that when because the health department gets the lab report first, generally speaking, they're, for things that are rare and important, like measles, they're like immediately calling the clinic and trying to get them to report and give them the information they need. And so they might be getting kind of an extra prompt or extra response or nudge for things like measles that they're not getting for all of the cases of hepatitis B. So speaking of timeliness, so we looked at the difference between the report date, so this is the date that was either written on the piece of paper by the clinic or which was automatically provided by the laboratory or printed on the lab report, and then the day of the test that was done. So we calculated the difference between that. For ELRs, the mean was about 1.4 days. So generally, providers get it either the same day or the next day. And that's just the nature of how ELRs work, because oftentimes the labs will send them in a batch overnight to us at the HIE, and we forward it on immediately to the health department. Or we catch it during the day and then send it to the health department at night. Either way, someone is looking at it within 1 day at the health department. Say with labs, when it's manually reported by the lab, it takes about 3 days for them to report, with the median being about 2 days. And then for providers, the mean is 9 days, with a median of 3 days. And I think, again, this is because the health department people are getting the ELR, then proactively reaching out to the providers to get the additional information they need. And so providers then respond within, for things like measles, they're supposed to respond within 72 hours, and they seem to be meeting that guideline. And then for other things, they're taking longer, which seems to be kind of the state of practice. And these numbers align pretty well with the existing literature on ELR reporting. Okay. So the next steps in our research is, so we have, just like with Erica, a few months left. We're going to finalize our data entry and then analysis of our post-intervention period. So that's where we're going to be looking at comparing the pre-populated forms, how many pre-populated forms were generated during the 1 year, how many were delivered to providers, how many got returned to public health from our intervention sites, and did that improve reporting rates and completeness and timeliness of information to the health department. And then we're going to synthesize all those quantitative data with the qualitative work that we did. We did interviews with both the health department staff as well as the clinic staff about Do you like the system? How is it working? Does it work well with your workflow? Do you hate it or not? And how has it changed things for you? And generally, I will say, in just the analysis of the qualitative data, people generally like it. People generally feel that it is helping them to remember to report things. And they are also, our clinics are also responding, like the labs, that they're starting to become dependent on it to tell them when they should be reporting things to public health, which is both a good thing from a, yes, my intervention is working, but it's also a little scary because then you start to think about, okay, how do we maintain this over time and make sure, then it becomes a production level system. We have to move it from a research project to a production level system to keep up and support practice, which is a whole nother ballgame. And then so also our next steps will be to then publish what we find in both our journals like the Frontiers in PHSSR, as well as AJPH and the Journal of the American Medical Informatics Association. And then we also have some upcoming presentations that we will be making at both the 2015 AMIA Symposium and then next year's HIMSS 16 conference. Those are both informatics, health IT events that take place. Okay, so some discussion some fodder for our discussion this afternoon. I think what our results are telling us so far, and again, we haven't finished our post-intervention analyses completely, is that public health largely needs to become more engaged in utilizing increasingly available e-infrastructures. So as EHRs are rolled out, there's a lot of interest amongst public health workers that these things should be leveraged. And I don't know how many of you saw the special issue of the Journal of Public Health Management and Practice from this month. There was a supplement that was with several articles about the PH Wins survey that ASTO did, where they surveyed a representative sample of state public health workers, and they asked all of them, have you heard about EHRs? Are EHRs important to your job in public health? And do you feel like you need to know more in the future? And it was interesting. Certain subgroups within state public health identified them as important. So the IT people, people who labeled themselves as informatics thought they were important. A lot of public health workers said they didn't think it was very important. And so I think, though, it is important because it is one of the ways that public health workers and agencies can tap into routine data that's collected from clinical practice and begin to use it. Also, these systems can help identify when reporting something is necessary, so they can become a decision support tool for clinical practice. And also, there's also opportunities to provide public health workers with direct access to information in electronic health records. So one of the things that we do in Marion County in Indiana is we give the nurse EPIs access to the Health Information Exchange, so that once they can identify a positive case through the ELR system, they can then go in and dig around and get additional details if they need to from the health system without calling someone. And that's really important because otherwise they're calling and playing phone tag with nurses and people in the clinic who are just, especially in primary care, are often overwhelmed with a lot of other tasks to do. And then, of course, this aligns very well with the CMS Meaningful Use Goals, and so why not take advantage of that opportunity? And then second, we have the opportunity, I think, going forward to expand this to other data that are not available in electronic laboratory reports. So we have the potential with the implementation of computerized provider order entry systems, electronic prescribing systems, and electronic pharmacy systems to go in and identify proactively treatment information and begin to feed that into the public health system. So again, it may be possible 10 years from now that we don't even need providers to send any information into the health department. We may be able to glean it all from electronic systems if we can get access to those systems and begin to incorporate those information flows into public health practice on a routine basis. However, today there are some challenges that I think need to be addressed through future research and practice. One is that the available infrastructure in all places is not equal. So we often talk about health disparities amongst the citizens, the population that we're taking care of, but there's also disparities among health departments and resources in different states. Some states have a very vibrant HIE, so you're lucky in the tri-state area to have HealthBridge. In Indiana, we have a great HIE. They have a good one in Maryland, but there are some places in the country where they don't have a good EHR infrastructure, or those EHRs don't talk to one another, and so doing this kind of work is more difficult. And so as interoperability can be improved with EHRs and more HIE networks can be built and sustained, then we have more opportunity in public health to tap into them. Second is that there's often concerns around data security and sharing information. So there are a lot of what I call privacy officers and information security officers in health departments and in health systems too. It's a problem on the clinical side that over-interpret available regulations and sort of say, we can't do that because it's a violation of HIPAA. And there's a lot of quality improvement projects that have been terminated because people are concerned that they can't use the data for quality improvement. There's a lot of problems in health systems right now with ACOs, and can we share data in order to do population health management, and people are running into roadblocks because of these concerns. And they're more concerns than real violations of law. And so I think we have to there's some educational issues there, some workflow issues, some cultural issues that we have to work through, much like what Erica talked about in her presentation. And then finally, it's often not easy to find information in EHR systems. So if we are going to give nurse case EPIs, for example, access to EHRs, we need like a Google search tool for EHRs, because otherwise you go in there and you get a whole bunch of documents or 500 screens that you have to look through in order to find the needle that you're looking for in that haystack. And so we need better tools to support public health practice as well in this intersection with the clinical world. Some challenges in this particular project, we faced some aging infrastructure and legacy issues. A lot of health systems have legacy systems. We were trying to implement this intervention at the same time. A lot of our legacy systems were being transitioned over into new platforms, and that caused a slight delay in us getting off the ground. And so those things always come up in IT implementation projects. Also, especially with vaccine preventable diseases, there's a lot of false positives you get from the lab because there's a lot of lab tests that just test for the antibodies, and that just means that doesn't mean someone has the disease. It means they likely were probably immunized for the disease, and so you have to be careful. And what's interesting is that there are several tests, LOINC codes, on the CDC's reportable conditioning mapping table that are antibody tests. And so out of the box, we sort of went with CDC's recommended list, and then we ran into some problems because we were over-identifying people, and so we had to back off of that. And then finally, when doing our analysis, one of the challenges we face is that there aren't very many cases of measles, mumps, or rubella out there, and so our one-year intervention time period may be insufficient to test for whether this intervention was effective for those diseases, but it's probably fine for hepatitis B, STDs, other diseases that are more common, and then allow for numerical quantitative comparisons. So I, too, would like to acknowledge some of the people. Dr. Sean Granis, who's my research mentor on this project at the School of Medicine at IU and the Regenstrief Institute. He's our Associate Director for the Center for Biomedical Informatics. Also, Dr. Joe Gibson, who is the Director of Epidemiology at the Marion County Public Health Department. He is my practice mentor on this research project, along with Zoe Zhang, who's our biostatistician, Jennifer Williams, who is my project manager extraordinaire. And then some of our collaborators at the University of Washington who've helped us with the qualitative aspects of our work, and then two of my students, one at the School of Informatics and the other at the School of Public Health. And of course, our work is actually supported not only by the wonderful grant from the Robert Wood Johnson Foundation, but also from a grant from the Agency for Healthcare Research and Quality. So with that, I will stop and see what questions you have. Thank you very much.
So I guess Anna stepped up for a while, so I'll take questions from the audience. So
Help moderate.
any questions? We have about 8 minutes to take questions.
Yes. So Brian, you mentioned that taking this work from research to practice is another ball game.
Yeah.
What are some strategies or that you have in mind?
So
Potential.
So good question. So how do we translate this into practice, right? So I think part of it is going to be education with the clinics. So we have to figure out what our strategy is. So for our research project, we went out to each clinic site. We had to sort of recruit them and get their consent to participate in the research. So we made a lot of presentations to the staff there. One of the things we found is that staff turn over quite a bit in primary care. And so it not only will require sort of an initial education with clinics to sort of say, here's the intervention. We promise it won't interfere with your workflow, because that's what they're always concerned about, and getting them over that initial hump, but then also constant retraining so that the staff are aware of what these reports are as they're coming in. Now, if they've practiced elsewhere before in the state, they know what the form looks like. But making them aware and keeping them aware of the system will be an ongoing challenge for that translation piece. So we have to figure out what our strategy is, and also I think we've got to have input from the State Department of Health to roll this out beyond Marion County. So locally, our health department is really excited about this. They want us to expand within the metro area, but then going beyond that, we'll take some work with both the rural health departments as well as the State Department of Health. And so those are some issues that we will grapple with. So we'll take a plan, buy-in, champions, all those things that we think about when we're implementing projects, and we'll have to scale that. Technologically, it will be fairly easy to expand within our health information exchange because these are systems that people are using today. So at least we won't have to do a lot of technical expansion. But those other things are really important, actually more important often than the technology, and they will have to be addressed. Yeah, good question. Yep.
Talking about, Anne was talking earlier about return on investment with the cases of the hepatitis B. Best case scenario takes care of us on its own. Worst case is a liver transplant. Of saying, we saw, this is our baseline, this is where we are, and the good and the bad with hepatitis B is it's a multi, free shots, kind of like the HPV vaccine.
Yeah.
Working with somebody directly to say, we had it here, we did this implementation, and we had ROI as far as missed work days or liver transplant or those kind of things that possibly could those things be looked at, like what you're saying about practice.
Yeah.
Building on that.
Yeah. So that's a really good point. So how do we demonstrate the ROI of this to the so if we want, say, the state to invest, if we want other states to invest in this kind of infrastructure, I think we have to make that ROI use case. And so I think that's a good suggestion. Now, we can't get that from ELRs. We'd have to go through, but we could do a nice, data grab from EHRs to follow long-term patient outcomes from earlier identification of hepatitis B cases. Although in many respects, ELR is actually identifying the case, which kind of sets things into motion. But yeah, I think in our case for ROI, it's showing providers that we can either we could minimize their current workflow, even if it's largely paper-based and clunky, or combination of paper and electronic and still a little clunky. We can improve that. We certainly won't make it worse. We can make it, and if we can improve it, that's even better. And then, as I said, in the long term, if we can actually start to glean from electronic health record systems some of those other pieces that providers today are so important to report. Like, we just don't know about treatment unless we get it from the provider. If we can get treatment and symptoms and other things for say hepatitis B and liver enzymes and other things out of EHRs more automatically, then we don't need providers or nurses or MAs, or they keep shifting their work down to lower and lesser paid individuals instead of just shifting the work to another lower resourced human being. If we can just use computers to do that, then the ROI is, we don't need you guys to do anything. We can get everything we need out of the system. We are not there today, but we could be there in 10 years, I think. Yeah.
What's your sense of how prepared other states would be to implement a solution like this? I recall when your proposal was being reviewed, one of the rules that Indiana is the only state in the whole country where this could happen. We have to do it.
Yeah, great question. So how do we implement this in other states? I think that what we're seeing in other states is this HIE infrastructure beginning to emerge. There are at least 24 states right now that have fledgling HIE activities in the country. And those are starting to get bolstered by ACOs. And so as the healthcare system moves to implements payment reform and restructuring to focus on population health management, they recognize they need to share data with each other because patients will go in and out of ACOs. And so that gives a good business case to sustain HIE infrastructures in this country. And I think that means that other states will follow those first 24 that were really successful with their high-tech money to stand up state-based exchanges. And then as the country, again, next 5 to 10 years, improves that infrastructure, then we will have the capacity to roll this out. I mean, it doesn't take a whole lot to do this work because you're relying on ELR, which are very common and required under meaningful use. So a lot of states have that infrastructure now. Even if they don't have an organized HIE to facilitate it, they have ELR activity happening. And so if you found a way to sort of connect the dots within your state, you could get that part of it. And then the second piece of this is getting information back out to the providers. The technical solution for pre-populating a form is pretty easy. There are lots of good standards now to do this, and so you could develop that relatively inexpensively. It's that part of getting information back out to the providers, which is somewhat of a problem in certain states. But as HIEs advance and grow and expand, that will become much more feasible in the coming years. So I think it would be possible to implement this in at least like a half a dozen states, in the next couple of years, and then a few more, and so it could easily be rolled out over time. Yeah, good question.
Okay, we have time for one last question. Go ahead.
Thinking about return on investment, which is something I didn't actually start thinking about until yesterday, finishing up my slides, but it ends up being an important part of both of our talks.
Yeah.
I'm wondering, it seems like some of the return on investment is less time for the public health workforce to be hounding the clinics.
Yes.
Right? Which is, I'm wondering, something that we had done in another one of our RWJ projects, it was for the delivery and cost studies, the DACs, is that we were looking at HIV and STD partner services, and we did like a time motion study because we weren't clocking them. But we did a random sample of cases, and we had them filling out forms to say how much time are they spending on different activities. And I'm wondering if that's something that might be helpful. So this would only be from the perspective of the public health workforce, but if you could show they're spending less time hounding clinicians that might help.
Yeah,
administrators?
that is an excellent point. Yes, very good. We proposed doing that, and we actually tried to do that in our study, and it failed. So, and here's the reason why. So we first took a look at gathering phone records from the health department, and so the phone company, who shall remain nameless, said yes, we would be happy to provide those to you for about $30,000. And it's like, wait a minute, wait, it's our phone. The health department was like, hey, those are our phone records, right? And like, you're highly subsidized by this anyway. So that was plan A. Plan B was then to sort of look at, the health department has a phone tree system, and so we thought we could get data out of their own internal system. That failed because all of the calls get lumped to one phone number, the main trunk line, whenever the nurse EPIs like call out to clinics. And so we weren't able to distinguish between nurse case managers. And so then we looked at these little devices that actually can plug into a phone and monitor every time the receiver sort of picked up and put down and what number was called. And so those are pretty inexpensive. However, they didn't attach real well to the phones that the health department used. So we tried that, and also it made hanging up the phone actually kind of problematic. So that did not fit well into workflow. So we took a look at that. Then the next thing that we did was we asked them to fill out a hand log. So we're trying to avoid the hand log, and so then they finally agreed, a couple of them agreed to fill out the hand log, and then when we went to collect them, we piloted this for the managers gave us approval to pilot it for a week or two. We did that, and we found that they logged a few calls, but we knew that based on their volume of stuff that was coming in through the ELR and the number of calls that they were making, that they weren't accurately filling it out. So we decided that it wasn't going to be reliable enough for our research purposes. But that is exactly what we wanted to do in this project, because we wanted to see, can we reduce call volume out to the, and so we tried it, and it didn't work out for us. But that would be a very important thing to do for ROI, but you almost need to hire a legion of grad students or something to go in and do the actual time motion study for that, as opposed to asking the practitioners to fill out hand logs. So I don't know if you have any.
In our case, I think the reason we were able to do it is because the main person from our Department of Health on the project, she did all sorts of site visits. She spent countless hours sitting with supervisors, sitting with staff, really explaining, here's the purpose of the study, here's how it's going to benefit you. We ended up having a site or two drop out anyways. If you look at our time, there might be more than 40 hours in a week. Some people might be working 100 hours that they claim, so there's always issues.
Right. Yeah. So, but yeah, that's
It
exactly.
requires an entire study.
Yeah. It did, and those are the practical issues you face in that kind of study. So we did for about a year, we diligently tried to do that so we could collect baseline measures before go live, and then we just said this is not going to be feasible. So.
Yeah, actually, Scott Frank, who's in Cleveland, who's an Ohio senior and public health leader, and he has this method where he uses student observers, and they sort of shadow whoever they're trying to measure their time for a sample of their time, or
Right.
varying samples. But anyway, he uses student observers and pays them to document. And it's used to, I think, enrollment study.
Yeah, I think if we were one of the things to think about is as we expand out to other clinics within the state, do we have an opportunity to do that with student observers? Because that'd be the next thing I would try is student observers, because that to me seems more feasible than having the staff actually try to fill anything out.
Your students wanted to learn about the work that
Right. Well, we have students constantly going into the public health clinic to do internships and month-long rotations and all sorts of things. So yeah, we could piggyback on that to have, while they're there, if they could log this stuff, it would at least give us a sample of work that we could use to extrapolate. So yeah, good.
So you should have this legion of grad students or undergrad students.
he says there's a lot of hats, and one of them is training.
Yeah. Well, see, that's good. That's good. That's what you would need.
Oh, okay. You want to ask one more? Yes.
Well, I just kind of question on the data that you couldn't get for the phone provider.
Yeah.
When we were at the Kentucky Public Health Data Trust, they talked about, we're going to ask you to come to the table first and play nice. And if you don't, there's legislature that's going to pass that's going to force your hand to share the information. So trying to get them to the table of those kind of things, is that also in Indiana, like it's happening in Kentucky here, as far as?
So are there multi-stakeholder sort of consultations or discussions involved to try to, get them more involved, provide this data?
For the phone company records, you mean?
Phone companies,
As an example,
how they're subsidized or how they're paid.
Oh,
You know.
yeah. Although in our, I honestly, I think in our state, the regulatory commission for utilities is, tends to favor the utility companies. So yeah, the lobbying is pretty strong. Yeah. So but the health department, the health departments are just, they try to do what they can to get the data from the health providers. But tackling these other bigger fish is even more difficult for them. Yeah.
So with that, thank you, Brian. We'd like to thank Dr. Dixon and Dr. Martin for
Thank you.